A silent killer in America. Opioid addiction has become a crisis, but pain is very real and doctors are tasked with trying to treat it without contributing to what has become a major problem. Our own Dr. Randy Schuck sat down with another doctor to discuss what those in their shoes can do to help.
Joining me now is Dr. Scott Powell with Florida E.N.T. and Allergy. Thank you so much for joining us today.
Thanks for having me.
So this is a tough topic. Obviously, Florida has a huge problem with opioid addictions. There's a crisis nationwide, so we're looking at all the problems we're having with opioids, narcotics, anything you want to call them as pain relievers. And there's an expectation that when you go to a surgeon, that you're going to need something very, very strong in order to overcome the pain that happens from surgery. Interestingly, is your surgical center is now trying a different way to address these pains because we know once we're in it, we got challenges. So why don't you tell us a little bit about the program that you guys are instituting and how it's working?
Yeah, so essentially from the first second of anesthesia straight through the post-op period, we're not using any opioid narcotics. There's still pain relief, there's other ways of handling that, but you avoid all the side effects of anesthesia, narcotics, and then afterwards you're not hyper acute to the pain, and so therefore the anti-inflammatories and Tylenol rotations have done wonders for pain control.
So go backwards a little bit, that hyperacute piece. Once we give someone a pain medicine, the body reacts to it. And then the way we perceive pain changes dramatically.
Right.
So you're saying that during surgery, you're not even using narcotics in there, so therefore the body responds better?
Yes, correct. They're not begging for more narcotics afterwards. So therefore, when we do an ibuprofen and Tylenol rotation, and we do add in some other modulators like a gabapentin or a magnesium, which have been great in terms of helping with pain, those things they're able to cruise right through and not have the spikes that come with the opioids.
Huge. And when we talk about opioids, the way they work, they don't go to the place where you made your incision. They don't specialize right in that spot. They go to your brain, and it makes your brain go, I don't care if I have pain or not. So it's only disguising the pain, it doesn't change it. But these other medicines actually change the way pain is perceived as well, but they also decrease inflammation.
Correct. And once we realized with studies that the anti-inflammatories like Motrin, ibuprofen don't worsen bleeding, it was easy for us to use those for pain control.
Sure. Now you talked about ibuprofen, Tylenol, gabapentin. Talk about the gabapentins, they're neuroleptic pain. So obviously pain is perceived in the body by the nerves, and so it only makes sense to go after the nerves, don't go after the tissue that you just cut.
Correct. So between that and also the magnesium helps with the nerve modulating as well, and it's really changed the game in terms of how we do it, to be honest with you. As you know, with the opioids, we're limited in terms of how we prescribe that. We can't call them in anymore. We have to get prescriptions ahead of time, and some patients still want that paper prescription for safety, and that's fine. We'll still give them a little bit for that. But we are stuck some physicians, surgeons are forced to get extra because they're afraid they're going to have pain down the road. And
then we talk about that as the rainy day syndrome, that people, I don't really need the pain medicines, but I'm going to take the pain medicines, I'm going to go ahead and fill the pain medicines, I'm going to put them in my medicine drawer, and then what happens?
There's the problem, and the studies are showing 20% are used, 80% are saved, and those saved, they're either using them for long-term use where you get addicted, or you're saving them and someone else is taking them or even selling them, and now you have a different whole problem.
Sure, and that's where we are at currently, is that there are so many people, obviously 80% saving them, and people recognize that. So they'd go to your house and they'd kind of go through your cabinets and find what you have, and all of a sudden your savvy rainy day medicine is gone, and someone who has a problem with the medicine has picked up their extra supply. So there's no way you really can protect against that, but what do you recommend if you do have pain medicine in the house? What should they do with it?
Well, at the surgery center as well, we give them disposal techniques. I mean, you can do as simple as flush them down the toilet, or you can dispose of them in other ways of crushing them and disposing them, environmentally sound, if you will.
Sure. And there are multiple places that have opioid take-backs. Fire departments, I don't know if they do that, but Walmart, I saw an app just the other day saying that they would take it back. Most pharmacies will take it back. So you have to, it's a safer environment for it. You know, we were always told that if you put it in the toilet, then the fish are all going to get high, but it's really not a true piece.
Correct. And so there's some concern about the pollution of the pills and so forth, but I think, like you mentioned, the take-back have been great because, physicians were trying to be on the forefront of how we can change this. Once upon a time, we were all told that opioids were the best thing and they were completely safe, and now we're at the full spectrum of not safe. There's a middle ground. We just have to find it, and we're just trying to change it ourselves. Sure.
Now, we've seen studies out of the CDC and other pieces talking about acute pain and chronic pain. And I think that's a huge piece for a definition. Obviously, acute pain means right now, but it shouldn't last, right? But chronic pain, for those guys who have chronic pain, they are looking for relief. How do you define the difference for these patients, and how should we treat them?
Well, once you get past the acute pain, like you mentioned from surgery, then it goes into a whole nother spectrum. And then there's going to be some issues where those nerves are going to be active for other reasons. Chronic injury, spinal and back injuries are a very common one. And there's specialists just for that. And for that reason, while some opioids are needed on a chronic basis, but there's newer ways to address those pain more succinctly and avoid the opioid chronic use. Because the problem is they need more, and they need more, and before long it's just part of their regimen.
Yeah. Now, when we talk about opioid use, it's natural. The body has opioids in them naturally. The body is used to responding to those, but when we start giving them over time, talk about tolerance and addiction, because those two things I think are very important, because people go, well, I'm addicted on day one. Well, that's not really accurate.
Yeah, so there have been some studies where some people on day one, they feel the sense of relaxation or benefit, and they like that. And so their addictive personalities perhaps continue that process, and they continue. And then over time, their tolerance builds up where they need extra pills, every single day pills. They require going to IV medications, and that's where things go astray. Some patients will take one or two and never have an issue. I think that's a whole nother psychiatric psychology issue, which we're blurring those lines heavily as we're giving these high-powered pain medications. One of the studies are showing something as simple as a Percocet, which is an oxycodone and Tylenol, work twice as well as oxycodone by itself. So inherently, is it the Tylenol is giving that much benefit? Well, that's what we assume, and that's kind of the avenue we're taking now with just pure Tylenol and ibuprofen type medication.
Now, there are limitations to these medicines as well. There is daily amounts that we are allowed to have to protect ourselves. So if you could just touch on the Tylenol daily use, how much they can tolerate, and then the ibuprofen, the side effects of those as well.
Yeah, so the ibuprofen type medications, you're exactly right. The kidney doses are a problem, not to mention gastric ulcers and gastric bleeding. So there's things you can give prophylactic to reduce that. In some cases, they can't. They have known bleeds or known issues, and opioids have a role. But once you kind of go low dose, only 400 milligrams every 6 hours or so, and then Tylenol around 500, the same problem as you worry about the liver in that situation. So there's certain dosage there, roughly 500 milligrams every 6 hours. You can't go beyond that, but usually once you alternate those two back and forth every 3 hours, patients after a few days are starting to cruise on their own.
Yeah, that's the most important part, is people get confused about the medications, the dosing, the timing. They've heard the bad things, they've heard the good things. They're trying to balance these things out, so it's impossible for a patient to do this from the internet or anything else. They need to talk to their doc, and we appreciate you coming in today and talking about it, because obviously this is a touchy subject, not just for the docs themselves, because we're afraid about giving patients the wrong medicines, but the patients themselves about being afraid to be addicted. So great information. I'm glad surgery centers are proving the point that opioids are not required for everything, and that they have their place. So thanks so much for your information today.
Thanks for having me.